Phase 3 of reflux therapy starts to go to surgical therapy, and I'm going to let Dr. Wilkin discuss most of that, anti-reflux surgery. I just want to say a few words about something, because if I don't say it, it's going to get asked. There's been a lot in the news lately about new endoscopic techniques for anti-reflux surgery, the endoscopic gastroplasty. It's a very new procedure. I have to tell you, I'm not trained in the procedure. I've chosen not to be trained in it right now. We're not offering this procedure at Boca Community Hospital. I think that the court is still out on this procedure. Basically, it's performed transorally. You put a scope down and you can actually perform the procedure through an endoscope. What it involves is placing stitches through the wall of the stomach just below the normal esophageal muscle sphincter and gathering up that portion of the stomach to create an extension of your esophagus down there and try to extend the valve that prevents reflux. It's a tedious procedure. In the best of hands, it can take 35 to 40 minutes. Now, generally a diagnostic upper endoscopy takes us 5 minutes, so it's a lot longer. And it requires the scope to be inserted, withdrawn, inserted and withdrawn numerous times. To do that, we have to put a stiff pipe down called the gastric overtube that goes into your stomach. Now, the proponents of this procedure say that it's a great procedure because you can do it under conscious sedation and it's quick. Well, if I have to endoscope somebody that frequently, it's not going to be quick. And if I have to put a big pipe or overtube down them that's at least 14 millimeters wide and leave it down there so I can insert and withdraw the scope several times, I'm not sure that conscious sedation is going to hack it. My feeling is that these patients are going to need more intensive sedation or even general anesthesia or something like Diprivan, which really starts to get into, well, if you're going to use that, why not go to a surgical procedure? I've reviewed the procedure. Most of the data on the procedure lists success for this procedure as a reduction in symptoms and a reduction in medication. Well, I'm not sure that's success. If someone's on 40 milligrams of Pt.6 and they're able to go down to 20, I'm not sure that's success. To me, success would be being off medication and having no symptoms. So, you have to read this literature very carefully to interpret success. In addition, this procedure doesn't last very long. Most of the studies I read say it can last maybe 2 years. It clearly doesn't last as long as other surgical procedures. And there is an advantage that it can be done again. You can redo it and redo it and redo it. But the longevity of the procedure and its effect is not very long. As you can tell, I'm probably not entirely sold on this procedure yet. I'm going to finish up discussing some of the roles of diagnostic testing for gastroesophageal reflux disease. I think one of the most overlooked diagnostic tests for reflux disease is a therapeutic trial of medication. I told you how good the proton pump drugs are, the Pt.6, the Prevacid, these medications. There's been a lot of studies that show if you give a patient a trial of this medication and they get better, they probably have reflux disease. This is a slide I have looking at omeprazole, which is Pt.6. It's called a PPI test. And you can see specificity and sensitivity are two ways we value a test. And you can see that it's very specific and very sensitive. So a response to this medication is a valuable tool. Other medications we use, and I'm going to go over tests that we don't, other tests that we use, and I'm going to go over and review briefly ones we don't even use anymore. There was a test called the Bernstein test that I was trained in. I've never used it. It's a test where you can put a small catheter in someone's esophagus and infuse acid. And if you can reproduce the patient's symptoms exactly, you've told them, you basically demonstrated their reflux disease and the symptoms that it caused by reproducing what's happening normally or physiologically. There's barium test. There is a role for barium. There's barium swallows, esophograms, or even pill esophograms. These can give you a very good idea of the structure of the esophagus. They're useful tools for investigating dysphagia or food getting stuck. They can give you an idea if there's a muscle problem in the esophagus. They can demonstrate reflux with the barium. The pill esophagram is a useful tool for patients with dysphagia to try to localize where the level of obstruction is. A pill esophagram means they give you a barium tablet that can be at varying size. It can be 13 millimeters, and you swallow the tablet and they track it under the x-ray equipment as it's going down. Endoscopy has sort of been a very important tool for reflux disease. Endoscopy affords you the ability to do a lot of things you can't do with any other modality. You can grade the esophagitis. You can rule out an infection, very important, especially in patients with multiple other medical problems. You can evaluate for Barrett's. It really is the only test available to determine whether patients have Barrett's esophagus. And in fact, current day, if patients have prolonged reflux symptoms, our society is and the Cancer Society is recommending at least a once-in-a-lifetime endoscopy in everyone with prolonged reflux symptoms to evaluate for the presence or absence